So why this is becoming so relevant now? So what we know is that over the past few decades, there have been a lot of studies showing that there are elevated levels of immune biomarkers in patients with psychosis, depression, bipolar disorder. So the reality is this, that something that we find across, again, the diagnostic spectrum. So it's not specific for one particular psychiatric disorder. And what is interesting, of course, is that most of these studies have been conducted on blood samples. So we are looking really at something that is happening in the periphery. And because, of course, mental health and psychiatric disorders, we always think about what is happening in the brain. One of the main things that I've been kind of quite interested in understand over the past years is there actually inflammation in the brain? So we see this kind of now hundreds of studies showing that there is inflammation, so increased inflammation in the blood. Is this relevant at all for the brain? And I want to show you, this is a systematic review and meta-analysis which we published just recently by looking at all the studies which particularly investigated inflammatory markers in the brain, like looking at postmortem studies or using PET imaging, so kind of an indirect measure of brain inflammation, and looking also at inflammatory markers in the cerebrospinal fluid. And this was specifically focused in depression. But I just want to give you a little bit of an idea of what we actually see. And this is one of the findings from our paper. You see here in the meta-analysis, we are looking here at the levels of interleukin-6, which is one of the main pro-inflammatory markers in the cerebrospinal fluid of patients with major depression, in comparison with comparison with healthy controls. And as you can see here, the meta-analysis suggests that already that also in the cerebrospinal fluid, we actually find the increased inflammation. So this seems quite interesting because it suggests that what we see in the periphery might be kind of a measure also what we may find at the level of the brain. And of course, studying inflammation in the brain is much more complex because there are different cells which are involved in the immune response. And one of the main players is really the brain macroglia. So the macroglia is one of the, as I said, one of the main immune cells in the brain. And one of the things that we were also interested in to understand if there was any specific abnormalities in the number of the macroglia or in the activation of macroglia in patients with psychiatric disorders. So we published this review a few years ago, and because of time, I'm not going to kind of start to tell you all the results, but what is interesting is that not all the studies go in the same direction. So there is a kind of a lot of inconsistency across the different studies. And this, of course, may be related to the methodology that is being used, but one of the things that we propose in this paper is the possibility that not all patients with psychiatric disorder present the activation of the macroglia, so that not all of these patients have a brain inflammation, but maybe a subset of patients with psychosis or patients with depression or bipolar disorder present with this macroglia activation. One of the things that also we discussed is the possible link with the peripheral inflammation. So the possibility that the peripheral inflammation may be in some way a marker of what is happening in the brain. And of course, this is much more complex than what we thought at the beginning. And we have one of my PhD students today also presenting a poster, so Maria Antonietta Nettis, which I think is poster 27. So just go and check, but she's probably presenting really a study looking at really the link between the peripheral and the central inflammation. What we see from the studies, in particular from the postmortem, is that the patients who present this macroglia activation, so those with the central inflammation, may be specifically also those with more severe symptoms or at least with suicidal ideation. So it may be that those who are kind of more presenting with these particular abnormalities are those who are also more treatment resistant and those who are not possibly responding to the current medication that we are using. And this is, in a way, an opportunity to think also about different treatment strategies with possibly anti-inflammatory treatment to target, in particular, this population. So one of the things, of course, that I'm being very interested in is to try to understand if this inflammation is really relevant to help us in the strategies for the treatment, is irrelevant for the clinical outcome. And I just want to show you a couple of examples here. So this is a paper that we published now a few years ago, and it was probably the first paper, I believe, that actually looked at immune biomarkers in relation to clinical outcome in patients with first episode psychosis. So what we did in this paper was to collect inflammatory markers at baseline in subjects who were presenting to the services with the first episode of psychosis, and then follow them up after 3 months. And at 3 months, we divide them in responders or non-responders on the basis of their symptoms severity, on the basis of the Andreasen criteria, so to try to understand if over the 3 months they were going into a clinical remission or not. And this is what we found. So here you see, these are the levels of interleukin-6, so of the immune marker at baseline, in patients with first episode psychosis who were not responding to treatment at 3 months follow-up in red, and the green are those who are responding to treatment, and the black are the healthy controls. So as you can see here, it's mainly the non-responders who have higher levels of interleukin-6 at baseline, not only compared with the controls, but also compared with the responders. So this is very interesting because this is a longitudinal study. So this suggests that already at the beginning of the illness, by measuring the immune biomarkers, we may detect those who later on are not going to respond to the antipsychotic treatment. And this was true not only for interleukin-6, but we found it also this effect with another marker of inflammation, which is interferon gamma, where again you can see that the non-responders had higher levels of interferon gamma when compared with the controls, but also compared with the responders. So this was very interesting and quite promising. What we've done over the past few years is also to try to move things a little bit forward. And we just recently published this paper looking at metabolic inflammatory status this time. And we looked at the clinical outcome a bit later on, so at 1 year follow-up rather than 1 year, rather than 3 months, sorry. So here you can see what we did again. These were again patients with first episode psychosis. At baseline, we collected blood to look at inflammatory markers, mainly the C-reactive protein, and then we looked also metabolic markers like the body mass index, the lipid profile, looking at triglycerides, cholesterol levels, fasting glucose, and glucosylated hemoglobin, so as a marker of glucometabolic status. And then we followed up the patients at 1 year. At 1 year, we looked again at the severity of symptoms measured with the PANSS, which is a clinical questionnaire for psychotic symptoms, and we look at the treatment response, so how the symptoms changed over the time. And because of the many variables that we were looking at, we decided to do a principal component analysis to try to cluster together the variables. And what we identified were mainly 3 factors. So one factor was putting together the C-reactive protein with the BMI and the triglycerides. The factor 2 was clustering together the 2 cholesterols. And the factor 3 was actually more the glucometabolic status, so clustering together the fasting glucose and the glucosylated hemoglobin. So we did a regression analysis, and this is what we published quite recently. As you can see, in the regression model was mainly the metabolic factor 1, which was the one putting together the C-reactive protein with the triglycerides and the BMI, which was predicting the severity of psychotic symptoms at T2 was a 1 year follow-up. And this was true also when we were putting together in the model the severity of symptoms at baseline. So what it meant basically was that those with a worse metabolic inflammatory status at baseline, so those with higher BMI, higher C-reactive protein, higher triglycerides, were those who were presenting with more severe symptoms at 1 year follow-up. And this was true also for the treatment response. So here the outcome is the treatment response. And you can see both metabolic factor 1 and 2 were associated with the treatment response at 1 year, but it was mainly the metabolic factor 1 which was predicting the treatment response. And because this is a symposium of transdiagnostic, I want to also show you that this is not only true for psychosis. We have also similar findings in patients with depression, and this is a recent paper that we published as part of the NIMA consortium and the BioDepth study, also led by Carmine Pariante, who is here in the audience. And you can see in these studies, this was a cross-sectional study, and what you see here is that the levels of C-reactive protein, which is the main inflammatory markers, are mainly higher in the patients with depression who are treatment resistant when compared with healthy controls. And although the treatment response, even the untreated patients with depression still tend to have a higher CRP, this is not as much as in the treatment resistance. So again, suggesting that might be a population, a subset of patients that are particularly those who are not responding to the antidepressants, who are those who present the increased inflammation. So I just want to conclude a little bit to kind of show you what we think is happening. As I said, we believe that there might be a particular subset of patients with increased inflammation among patients across diagnosis. I didn't go into a lot of the details about what could cause the inflammation, and we may need a different lecture for that. What is interesting is that we see both the presence of central inflammation and peripheral inflammation in these patients, but the link between these two is still something that we really need to try to understand better. And I really encourage you to go and see the poster of Maria Antonietta Nettis to try to understand a little bit more about that. What is interesting is that we see this effect of immune metabolic markers, and we have also another posters looking also at obesity, and that is the poster of Anna McLaughlin, number 26. So you can also look what is happening in patients who are obese and depressed. But basically what we see is that the possibility of identifying immunometabolic markers, which may guide us a little bit more in trying to understand who is going to respond to treatment and eventually guiding the treatment strategies. So the next step is really to try to do clinical trials by selecting really patients according to the biomarkers. And to be honest, this is what we have done already. So this is just to say that the BRC funded this work. We did a MINDEP trial, which is a clinical trial using minocycline, which is a main anti-inflammatory drug, and we selected, in this case, patients with treatment-resistant depression who had increased inflammatory markers at baseline. So we just completed the recruitment, so I'm not going to show you, unfortunately, the results, but probably next year we will be able to tell you a little bit more about that. And with this, I just want to finish by acknowledging the people who work very hard behind this data. Of course, Maria Antonietta, Nagme, all the people in the SPY lab, and the GAP study, and the BioDepth study, and the funding in particular, of course, the BRC. Thank you very much for your attention.
Thanks, Valeria. So we have some time for a couple of quick questions. So one in the middle and then one there.
Thank you. That was a very nice talk. This is a comment, a plead that this is a point that people in the biostatistics department have made many times. When you're looking at a longitudinal study and you're just looking at a treated group, you can't talk about the change over time as being a treatment response because there is no control group with whom you're comparing them. So what you've got is change over time under a particular treatment regime. And the importance of this is it changes your conceptual understanding of what the inflammatory marker might be involved in. The way when you call it treatment response, and divided it by inflammatory marker, your mind is immediately taken to an interaction somehow between the treatment and the inflammatory marker, when it could be anything to do with the progression of that patient over time. And it's, the terminology when you use treatment response focuses on that particular interaction, which is misleading because there are all sorts of other things that are influencing the progression of the patient other than their treatment. And without any comparison group, we've got no way of exploring that.
Thank you, Andrew.
And question? I think there's a mic here, so you can.
Yeah. Yeah. Thanks. That's very interesting. So, actually, I just looked this up as to whether a causal relationship between inflammation and mental, like depression, for example, has been established. And I see somebody has just done Mendelian randomization. Do you have what's been seen about that?
Well, there are a lot of studies actually supporting this, and it's not only there is the work from Mendelian randomization. I think is the one from Golam Kandekar that you're.
Yes, from
so
Bristol.
That is one of the studies, supporting the fact that the inflammation is preceding the development of depression or psychosis. There are works also, from just kind of delivering immune challenges. We know from, patients who are receiving, for example, interferon alpha as part of their treatment, who have a higher prevalence of depression. So there are a lot of studies in a way supporting that there is a causal relationship.
Very interesting.
Thank you.
Thank you. Thanks, Valeria. So moving on.